Good morning to all. A little correction as she has given the introduction. Today I am here as a individual capacity. My CEO as NABH term has finished in 11th of this month. So, so you can say today is ex-CEO NABH. But definitely whatever capacity I am here, definitely we are for quality and patient safety in our country. Before I further talk, first of all, let's understand the delivery of the healthcare services in our country is by public as well as private sector. In the recent decades, there has been a transformation from public healthcare facilities to more private or corporate sector. If we see today, when we talk about indoor care, more than 60% is by private sector and only 40% is the public healthcare facilities. And we come to OPD consultations, it is as high as 78% from the private sector and rest is from the public sector. And why today we are talking about accreditation or quality and patient safety? Why we are discussing today? Is it a new concept? It's a very old concept. Even in the oath we take, or the Florence Nightingale, I presume everybody knows who was Florence Nightingale. Even 140 years back, she also said, do the sick no harm. It means patient safety is a very old concept, but still today we are emphasizing on quality and patient safety. Florence Nightingale was the first lady to use medical statistics. And what are the issues? We know already it has been spoken by Dr. Sundaresh about the medical errors. This patient safety and quality issues are medical errors are a major concern. We do not have a national database, the degree of harms being done to our patients by our hospitals. This is all data we use is from the advanced countries, which is uniform from all over, from Australia, US or whatever you say advanced countries. In general, 1 in 10 patients, adults, contract infections in a hospital. It means hospital acquired infections, which is such a high figures. 1 in 10 patients receive wrong medication or a wrong dose of drugs. And if we see the deaths, this is a 1 decade old IIHMR Institute of Medicine report, almost 98,000 to 1 lakh deaths annually occurring in US on account of medical errors. Today, this medical errors is a third leading cause of death, and such a large degree magnitude of problem we need to improve. That's why we are discussing here quality and safe care or the patient safety and accreditation. When we talk about quality, the quality we learn from industry, and always we compare with the aviation industry as a gold standard for quality. But there is a difference between the aviation industry and the healthcare industry. In the aviation industry, one pilot has to only fly 1 or 2 at the most aircraft, and he knows if something wrong, accident happens, he is also going to die. What about in healthcare? Doctors, all other concerned, because they do not have this potential threat that they will also die out because of the medical errors or any harms being done to our patients. So we are slowly improving, but at the pace which we should improve, we are not. But definitely we are learning from aviation industry to standardize our processes and systems for quality. And why this error happens? No individual is held responsible for medical errors. There are number of studies. The most significant important factor for error is lack of communication. This communication which we talk about is maybe a clinical communications, how we record the clinical histories or examination finding, the procedures that are being done, how we are recording, documenting them, or when we talk to our patient, the family attendant, what information we are exchanging with them. And same way in the non-clinical communications. Definitely, this is the one area I feel which requires a great improvement. If we improve our communication, more than 50% of the problem can be solved on account of medical errors. And different people call this quality efforts in healthcare in a different way. Joseph Juran, he said quality in healthcare is fitness for use. Philip Crosby said zero defects. And Edward Deming said never ending cycle of a continuous improvement. This is what today we say. Quality is that continuously we work for improvement. This is not an end point. Accreditation, getting an accreditation. Recently your hospital has got accreditation. No? Congratulations. It does not certify that quality is you have achieved the maximum. That's why accreditation is being granted to the hospital. No, I say this is the beginning of a quality journey. That hospital continues further to demonstrate improvement in quality. And certain definitions, since majority of the students here, for their benefit, what is a medical error? We define a medical error is a failure of a planned action to be completed as intended, or use of a wrong or inappropriate or incorrect plan to achieve an aim. And what is a sentinel event? It is an unexpected occurrence involving death or a serious or physical or social injury of more than minimum 2 weeks duration, or the risk thereof. Serious injury specifically includes loss of limb or a function. Can anybody name few sentinel events, most common sentinel events we see in the hospitals and which are not reported, or sometime media we see in the media, those are reported indirectly? Wrong side surgery, yes? Wrong patient, wrong side, wrong surgeries. This is one group. Any other? Fall of a patient. Left inside a cavity during surgeries. What else? OT death. Yes, that is also sentinel events. Simple thing like bed sores. When patient was admitted in ICU or a ward due to long stay, if patient develops bed sores and he dies or seriously get disabled, this is also a sentinel event. There are a lot of media reports, fires, floods. These are all sentinel events. Or in the NICU, again this was in media, newborn care centers, there were fires in the incubators, due to which the babies got burned, injured, a few died. Any suicide in a hospital by a patient or an attendant is also a sentinel event. These are some of the examples of every hospital can define the list of the sentinel event which should be reported and analyzed. Because when we talk about medical errors, this is not only for reporting or to know. All these adverse events need to be analyzed thoroughly. Root cause analysis to be done, so that corrective actions are taken and modified plans are in place to prevent the recurrence of that again errors. This is the logic. Then medication error. Medication error is relation to the drugs. These errors, the drugs related errors start from even manufacturing stage. Something wrong in the manufacturer level. From manufacturer level to even transportation, even some drugs are required, especially the vaccines, in a cold storage. If that is not there and that reaches the patients, there will be no effectivity. That is also a medication error. Or when a drug is administered, some wrong dose is given, or a missed dose is given, or something else goes wrong with the drugs. And then last is monitoring of the patient after drug administration. After every drug, especially the infusion, when we talk about IV injections, every patient needs to be monitored minimum 10 to 15 minutes, and there should be documentation of any adverse event noticed. If that is missing, even that also comes under medication error, or a wrong prescription, a wrong dose. This is all comes under medication error. Adverse event again is a broad unintended injury or a complication resulting in death, disability, or a prolonged hospital stay that arise from healthcare management. And near misses is same as sentinel event. Only difference is that damage was prevented. That adverse event never happened due to an intervention or due to by chance. That is near miss. Near misses are more important to be reported. There are few examples. Injection peptides 2.2 gram IV 8 hourly omitted on so and so date in a case file, but it was noted in a treatment book till some other date. Patient got 3 extra doses of injection peptides. This normally happens on the rounds. Doctor advise the changes in the medication for a particular day, and staff nurses, as traditionally, they have to revise in the treatment book. But if they forget, they do not make corrections in the treatment book, the same old treatment continues. Patient gets that treatment. That is again a error. This is a real life example. In the operation theatre, a plastic fall fan left open in the OT complex. Generally, operation theatres, routine operation theatres, they close at 4 or 5 p.m. On one particular day, there was no light, and that time when the OT was closed, the fan was closed. In between, the light came and fan again started working. Next day was a holiday. The whole night fan, it was a plastic fan, continued to function, and because of the overheating, it started burning. In spite of all sensors installed, smoke was detected quite late, and this adverse event was prevented to a large extent. But why, in place of sensors in place, why there was no timely alarm? The analysis was done. It was found that in particular room, there was a heat sensor installed, but smoke sensor was not there. And when a plastic body burnt, it produced a lot of smoke rather than high temperature. That's why the failure of the alarm. It means when we talk about fire safety, we have to ensure the smoke alarms as well as heat alarms. Both are in place in a particular areas. A staff nurse informed resident doctor in the ICU that patient on bed number 10 is having tachycardia. Resident doctor was half asleep at 1 a.m. and attending another patient ordered digoxin to be given. Staff nurse gave some digoxin dose and patient died. What is wrong here? Can anybody guess? It was a wrong patient identification because patient was identified by bed number, and bed number patient changes. It was a pediatric patient, and staff nurse gave an adult dose, thought is an adult patient on the particular bed. Again, this is example of a communication problem. These are the media reports we see. recently we have come out with a separate standalone standard for eye centers, eye care facilities. When we were talking to the expert groups, they say cataract eye surgeries are absolutely safe without any errors. There's no complications of any, no chance at all. But we showed them the media reports. Every 3 months or 2 months, you will find one media report. Patients getting blind or their vision is affected adversely after cataract surgery. It's not only in camps, but in hospitals, in nursing homes also, these adverse events are reported. Only with great difficulty, expert group was convinced. They agreed to the OT guidelines of at least a journal surgery. Otherwise, they were saying there is no need for an operation theatre-like environment for a cataract surgery. Healthcare acquired infection. There are few studies in India available. This was reported from one of the article published in a journal. From 12 studies, WHO says 7 to 11%, 7 to 12% hospital-acquired infection burden is acceptable. But in these 12 reports, the incidence of SSI, surgical site infection post-operatively, was varying from 11 to 83%. Majority studies were more than 50% infection rates. So such a high infection rate in our scenario and antibiotic prescription practices. There were a few studies from WHO. This data is from WHO. A high number of drugs per patient encountered suggested means inappropriate use of high antibiotics. Today we are facing antibiotic resistance. It is a crisis, emergency situation. We need to act for rational use of antibiotics. It's not only antibiotic, rational use of all drugs, but specifically when we talk about antibiotics, every hospital need to have, as per the scope of services, need to have their own antibiotic policy, and they should show compliance to rational use of antibiotics. Otherwise, in the next 10 years, not a single patient will be able to treat in ICU. Even today also, we are finding there are only 1 or 2 life-saving antibiotics which are sensitive to some organism. Otherwise, antibiotic resistance is a major crisis situation. We all doctors, administrators need to act immediately to control this, otherwise it will be a real problem in future. But injections, 4.8 billion injections per annum are given in our country. 82.5% are for the curative purposes and 62.9% are considered unsafe. In spite of so much of awareness regarding unsafe injection practices, still this is a recent data from WHO, and 70% of the injections are unnecessarily, because most of our people, especially the laborers, daily wagers, they go to a doctor and ask for some injections because they know if one day additional fever or some illness, they are going to lose wage for that particular day. They think injection is the only therapy, they will get quick response, and doctor also listen to them and give them unnecessary injections. So this practice we need to curb. Next please. Now in our India, what is the status of quality management systems and accreditation? In 1980s, people thought in the healthcare does not require any quality management systems. Whatever we do right practice. We are qualified and we do not do anything wrong. And regarding accreditation, they say why it is, what is it, and why we should go for accreditation. In 1990s, let us try, no harm in having a quality management system in place in the hospital. And regarding accreditation, few chains of the hospital, big hospital, they agreed, yes, there is a need, but they found not so relevant for healthcare industry. But what about in 2004? Everybody thought, yes, it's a useful tool to have a quality management system in place, and accreditation, this now in 2004 onwards, they felt is required urgently, and red alert was sounded. And various national and international forums are working on patient safety goals. This patient safety, this medical harms we have been discussing so far. The few common patient safety goals are patient's identifications. This is self-explanatory. Wrong patient, wrong site, death. Improve communication and handoff. Handoff means whenever there is a shift change, whether it is a nursing shift change or a doctor's shift change, what about the handoff? Over is given regarding the status of a patient to another staff member. That is called handoff. And then medication safety, prevent hospital-acquired infections, identify patient's risk, prevent wrong site, wrong patient, wrong procedures, and fall prevention. In a hospital setting, a lot of unnecessarily patient falls are registered. And sometimes, even because of the head injury, they even die also. This is also one of the important patient safety goal. And then patient satisfaction or experience. Nowadays, it's not only patient satisfaction, patient experience is recorded. The key principles of patient safety framework are: patients are the primary focus. Everything, hospitals are meant for patients. Time is up. Yes, I will take 5 minutes, please allow me. Organizations create a patient safety culture. Information about adverse event is shared in a transparent manner, and system approach to understand system complexities. Continuous quality improvement. Building blocks are governance and leadership. Peoples and teams, environment and equipment, and strategic initiatives are taken that constitute the safety principles. Accreditation is a word trend, and healthcare quality means doing the right thing, right way, the right time, in the right amount for the right patient that does not result in harm to a patient. And domains of the patient quality in healthcare are a care which is safe, which is effective, efficient, patient-centric. Now is not only patient-centric, family-centric, and equitable and timely. And the most acceptable definition of quality in healthcare is given by Institute of Medicine in 1990s, that it is, we can define quality in healthcare as quality of the care is the degree to which health services for individuals and population increase the likelihood of desired health outcomes and are consistent with current professional knowledge. Note the last line, please. Quality, what is today? We are doing excellence. Maybe after 5 years, that excellent quality may be a poor quality. Because in 5-year time or 10-year time, the advancement in technology, advancement in instrumentation, advancement in treatment protocols may change. If one continues to adapt to the old systems, the old technologies, that is not quality. It is a dynamic process. So along with the time, one also has to continuously improve and demonstrate that excellence the accredited hospital has achieved. I will just skip through the slide because of the paucity of time. A few questions. In a hospital, who drives a hospital? Who runs a hospital? It is the CEO, it is the medical director, doctors, nurses, or somebody said patients. Somebody said nurses. No, all. It's a team approach. All are responsible to bring a change in transformation in scenario or attitude. For a change in healthcare scenario means accreditation, quality and safe care. Everyone individual is responsible. Maybe it is a CEO or even front desk staff or even sanitation staff. All are responsible, all have a distinct role to play and act according to the job role assigned, and they all work together in teams. A leadership along with cohesive efficient working teams is the answer for a efficient working of a hospital. Is some approach change from the current and new approach. They say, do no harm is individual responsibility. No, now they say, no, safety is a system property, it's not individual responsible. Information is a record, because all adverse events, all the central events, they are treated as secret documents. Rather, they should be, knowledge should be shared, and then information flows freely. Secrecy is necessary. Now we say no, transparency should be there. And system react to needs. Whenever something happens wrong, then system will react to that. No, our approach is needs are anticipated, means risk-based management. We must analyze, apprehend the risk, what are the risks involved, and take corrective actions, proactive approach. Professional autonomy drives the variability, and decision making is evidence-based. Practice evidence-based medicine. And just culture, I will skip these slides. In broad, the 7 steps to patient safety and quality are: build a safety culture, lead and support your staff, integrate your risk activity, promote reporting of errors, and do the root cause analysis and further action, involve and communicate with the patients and the public, learn and share safety lessons, and implement solutions to prevent harm if safety designs are in place. Safety culture, basically it is a mindset. Change of mindset is required. That is, what is a culture, by the way? We are talking about patient safety culture. What is a culture? What do you understand by a culture? It is a bunch of good habits. Whatever we do in a uniform way, if we imbibe them, this is a culture. We know the variability in our country. At some, you can see the one patient in a room, there are 3 staff nurses taking care of that patient. On the other side, there is a long queue, infrastructure, lack of infrastructure, and patients are waiting for the turn. So we have to work in these both the scenarios and develop a system which improves the affordability, accessibility of healthcare and quality of the healthcare. The drivers, who is driving this patient safety initiative or quality in healthcare accreditation, is the rising consumer expectations. Nowadays, doctor is no more a godly figure. Patients, they know very much. The Google doctor is there. From the Google search, they know sometimes much more than a doctor knows. They come and want to discuss. They have very large expectations from now. They want quality services. Whatever is being done, they want to have a discussion and they want information to be given to them. Consumer Protection Act, everybody knows the litigations are rising. Competition, insurance. Recently, the Insurance Regulatory Authority also has notified for all healthcare facilities which are empaneled for insurance purposes, especially the cashless, a minimum entry-level accreditation certification by NABH or equivalent system is necessary in a 2 years' time. Then regulations, it is the regulatory compliances which drives, and most important is the public. Nowadays, I say biggest driver is the public which will drive to bring a change in our healthcare scenario. NABH, now coming to a little bit about NABH, what is NABH and what we are doing, is one of the constituent, NABH is a constituent board of Quality Council of India. Quality Council of India has 5 boards. NABH deals with the healthcare and rest of the boards are dealing with the other quality areas. And vision of the NABH is to be apex national healthcare accreditation and quality improvement body functioning at par with global benchmarks. And various programs we are running. Accreditation of the hospital is our major program. Accreditation of the blood banks. And beside this, we have a accreditation programs for Ayush system also. Ayush means Ayurveda, homeopathy, yoga, siddhi, wellness centers, and like that. And new program we are added is the eye care standards. Standalone eye care hospital will have a separate standard for that. And what is the importance of Ayush standard? In the last 6 months, we are focusing on Ayush because it is we know we are struggling with affordability, quality, and accessibility. And lifestyle diseases discussed in the morning, diabetes, hypertension, and lifestyle changes, our work culture has changed, is the integrated holistic approach by combining the two systems, the modern system and the Ayurveda or other systems, is the answer for affordability and accessibility and quality in care. Because most of these lifestyle diseases, diabetes, hypertension, prevention and promotion, where Ayurveda has the upper edge, yoga now, from yoga is the Indian origin from India. Today the world is celebrating Yoga International Day. Why we should not integrate or make use of these systems? This we should integrate. I am integrating the two systems so that more and more, especially in the tier 2 and 3 areas, there is a demand for yoga and Ayurveda wellness centers for prevention and this as a promotion of the health activities. And overall, if we see, I will just skip this slide. This is not working. Next, please do it next. Everybody knows what are the benefits of accreditation. What does NABH certificate accreditation means? Commitment to create a culture of quality and patient safety, efficiency and accountability towards patient care. Establishment of protocols and policies as per national and international standards. Patients are treated with respect, dignity and courtesy at all the time. Patients are involved in care planning and decision making. Patients are being treated by qualified and trained staff. Feedback from patient is sought and complaints, if any, are addressed by accredited hospital. Transparency in billing is availability of tariff list is there, and continuous monitoring of services for improvement. Commitment to prevent adverse event that may occur. So any kind of certification, whether it's NABH or any other international certificate, does not guarantee in that particular hospital there will be no error. Only we can put system in place, processes are in place so that these errors are minimized. If we see it as on date, 435 hospitals are accredited by NABH under the full accreditation program, and another around 84 small healthcare are certified. Overall, if we see, there are 1,140 various healthcare facilities certified under various programs of NABH as on date. And from Karnataka, 36 hospitals are accredited under NABH full accreditation program. We know in our country there are roughly around, I say, by estimate is 80,000 hospitals, healthcare facilities. Majority are small healthcare. And from this 80,000, the figure I have just shown, only 1,140 healthcare facilities are certified in some kind of the program in our India. What about the rest of the facilities? Because they find it difficult to go for full accreditation. So we have devised a stepwise approach to improve the healthcare scenario at every healthcare facilities, that is by entry level, progressive level, and the last is the existing or full accreditation. Besides this, we have a separate few more programs, certificate programs like SAFE-I. SAFE-I deals with hospital infection and prevention control program only. Nursing excellence. If nursing care of a hospital can be improved, 80% of our job is done. And then the medical laboratory improvement, and new addition we have developed, one additional program last month only we have launched, is the emergency department of a hospital. If we can improve the emergency services of a hospital, I think more than 60% of the problems are taken care of. Because major problem, patients' unsatisfaction is because they do not get appropriate treatment in the emergency department. Hospitals now having more than minimum 25 beds and having a separate department of emergency, then go for emergency department hospital standards. Entry level standards, as on date we see there are 161 hospitals, they have achieved this entry level certification from NABH, and another 78 are certified against the SAFE-I program for patients, this hospital acquired infection control and prevention. Entry-level standards are derived from our main standards. They are sufficient to provide a framework, just 1 minute, last slide. Provide a framework for quality improvement, focus on improving patient safety, and they set the basic standard that all organizations must achieve. And if we see the full hospital accreditation program has 636 objective elements. From those objective elements, entry level are only 167. So hospitals is very easy. If they have a commitment, some initiative to have start quality journey, they can go on join entry level program of the NABH, and within 3 to 4 months they can get certification done if their mindset is there. An audit cycle, every accredited hospitals, their validity is for 3 years. During this 3-year validity period, there is a surveillance system after a visit is done after 1.5 years. And again, at the completion of 3 years, again a full assessment. And now this for re-accreditation, the focus will shift from higher quality compliance and then surprise assessments. In addition to these, by a computer random survey, we do select one hospital for surprise visits every month, or on basis of adverse feedbacks and complaints. If serious in nature, we again conduct a surprise assessment of that hospital against the compliance to standards of the NABH. And quality is only we say it can be measured. We have defined around 64, now in the 4th edition around 70 indicators, KPIs. Every accredited hospital need to capture and monitor and evaluate those indicators. Out of this, 12 they have to send a mandatory to NABH every quarterly. And this is a few example of how we analyze the data. I will just, because of shortage of time, I will take home message is that reason for us being here is to create awareness, to will to change, to make commitment, to identify problems and challenges, understand the causes, and develop solutions, and implement change, embed in everyday practice. Monitor, and because this is only collaborative efforts, nobody alone, no organization alone can bring a change in the healthcare industry. Everybody, you have to collaborate, whether it's a government or a private or a students or whatever, doctors, nurses, everybody, all organizations, associations need to work together to create awareness and develop the system of accountability and transparency in healthcare system. Remember that in our country, compassion, the human touch and empathy existed, and remember that this must continue. Thank you.